Kerala, and he's called as the father of gastroenterology. And he was the first DM gastroenterology. And let me salute Professor Balakrishnan before I start this session. We have a number of excellent panelists here, and Professor Paul Gibbs will be joining us soon. And, I think that the liver transplant is a very important issue, because we know that it was in 1995 that the first liver transplant was attempted in India. But it took 3 more years before the first successful liver transplant could be done. It was in 1998 that the first successful liver transplant was done in India. And it is the 25th year after transplant. Now the thing has grown so much that there are about 100 centers doing liver transplantation in India. And they are doing almost about 1,800 to 2,000 liver transplant every year. And so before we go into the details of this thing, we will introduce the panelists one by one.
So again, it's an honor and privilege to be here. And in the memory of Balakrishnan sir, this session is named. As we all know, he was the first, one of the first gastroenterologists in India from PJ Chandigarh. He was the first batch. Chronic liver diseases and liver transplant is a significant problem. Chronic liver disease is a significant problem, and how much transplantation is going to address that issue, we'll be dealing with this in the session. So here we have a good panel here, Dr. Subhash Gupta and Dr. Shabir. Dr. Subhash Gupta from Delhi. And am I audible? And Dr. Shabir from KIMS, they're on the way. Actually, a liver meeting was going on at Puvar since yesterday, so he is on the way from there. Dr. Paul Gibbs from UK, unfortunately could not make it, but there may be a video session which he has sent actually. So to introduce, I don't think Dr. Sudhindran needs any introduction to this audience. He is an alumnus, a proud alumnus of this institution. And to be short and crisp, he was the first person to do liver transplant in Kerala. And he just one day decided that he's just going to do a liver transplant. There was a DDLT patient lying in one corner of Amrita. He went and did everything on that patient. He stabilized the patient himself. The concept of brain death was just starting to emerge among his colleagues and the other people in the institute itself. And I know the background. He went and convinced the people that this is brain death and that person is not going to live. And he mobilized everything and successfully did the first transplant in 2004. There was a lull of about 3 years after that. And then he had to do a lot of homework. He and his team did a lot of homework. And then now they run probably the biggest transplant center in Kerala, doing about 100 transplants a year. He was extensively trained in UK over 10 years in Birmingham, and he is now a world authority on transplant, conducting a lot of randomized trials as well on the subject. To introduce Dr. Krishnadas, over to Naren sir.
We all know Professor Krishnadas is MBBS, MD and DM from Medical College Trivandrum, and he is the professor and head of the Department of Gastroenterology. One of the things which I would like to say here is that he has recently put the department, our medical college, in the research firmament of India. You know that in a few weeks back, there was the Indian Association for the Study of Liver invited papers from all over India to select the best doctor, the best young investigator award. And they select 5 papers. And you know, 3 of the 5 papers were from Trivandrum Medical College. And I think his interest is made, and he's focusing so much on research. And the students who are leaving him are continuing to do research, and it's a great thing. The present Dr. Krishna is interested in fecal microbial transplant, chronic liver disease, acute kidney injury and chronic liver disease, ACL, of acute and chronic acute liver failure and chronic liver disease, and predictors of severity in liver disease. So we are honored, Dr. Krishnadas. Welcome. And now I will introduce Dr. Arun Arun has also the MBBS and MS and MCH from Medical College Trivandrum, and he's at present the Associate Professor of Surgical Gastroenterology at the Sri Gokulam Medical College, Trivandrum. And 2009, he was the postdoctoral fellowship in hepatobiliary and pancreatic surgery at the Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. 2011, he had a fellowship in liver transplant under Dr. Subhash Gupta's Center for Liver and Biliary Sciences in Indraprastha Apollo Hospital. 2012, he was a visiting fellowship at Penn Transplant Institute, University of Pennsylvania in Philadelphia, and he's an excellent laparoscopic surgeon. It is said that he can make the laparoscope talk. So welcome, Dr. Arun.
We'll get started. I think first question is
Sudhi and Krishnadas. Okay. So I think now let us go back to the program as such. Now about the indicator, it is said that out of the 25 to 30% of liver transplant that occur in India are done in foreign nationals. I don't know whether it is true in Kerala, but it is.
No, sir. Here, 99% are in.
99% are in India. Okay. And so I think we know that the spectrum of chronic liver disease is changing. So we'd like to know what are the indications for liver transplant as you see it now.
Me?
Yeah.
Yeah.
You.
So, majority of liver transplants will be performed in patients with chronic liver disease or cirrhosis. But just because somebody has got cirrhosis does not mean that they require a transplantation. So the term is decompensated cirrhosis. So usually it will be somebody who has got resistant ascites, or who has got encephalopathy, or who has audible now, yeah, or who has organ failure like kidney failure secondary to the liver disease, or if he has developed a hepatocellular carcinoma in the liver. So these are the usual indications for a chronic liver disease patients to have a transplantation, that is decompensated chronic liver disease. That makes up almost 75% of the patients who require transplantation. But about 25%, that is in our practice, it may not be that high in the West, but in our practice, 25% occurs for acute liver failure. That is somebody who's never had a liver problem, that is a normal liver. It could be young people, usually they are in the 20s, and they had developed an acute liver failure, usually due to viral infection, sometimes A, sometimes B, sometimes non-A, non-B, sometimes we don't even know what it is. Or it could be drug-induced. That's another common cause here, drug-induced. For example, many drugs, Ayurvedic drugs, people have the belief that Ayurvedic drugs do not cause any problems in our organs, but it is completely untrue. Many Ayurvedic drugs are very poisonous. Likewise, our own allopathic medications, for instance, anti-tuberculous drugs or anti-epileptic drugs, etc. can cause. And one peculiar problem in our situation is rat poison, elevation, sadharana elevation. Elevation kodutha eli merikilla, but if you take it, humans will die. And it takes about a week for it to act, and it is a very, very, very strong poison. So these are some of the common causes.
Coming to cirrhosis, I think there has been a great shift in what is causing cirrhosis. Previously, we used to have about 50% was alcohol. Maybe 20 to 25% was hepatitis B, and another 10% would be hepatitis C, and the other 10 to 15% we used to call it cryptogenic. Now the pattern has totally changed. Now it is basically metabolic disease associated liver disease, which is on par with alcohol. Maybe 40% is metabolic disease associated fatty liver disease, and 40% is alcohol. Hepatitis B has come down, and hepatitis C, I think within 10 years will be gone because of the, we have got a very good government program which gives drugs free, and the practices, injection practices, blood transfusion practices have all changed. People are a bit more knowledgeable about how you get this infection. So hepatitis C is definitely on the way out. HBV will be there for some time more, but with all these vaccination processes, maybe in another 30 years, HBV will also be out. So we will be left with basically alcohol and metabolic disease associated fatty liver disease. As you know, Kerala is a metabolic capital of India. We have got maybe 38% of our population is obese. And over 4 years, it has jumped up by about 8%. So you can just imagine 38% is obese, and 70% of these will be having fatty liver. And of all the fatty livers, maybe 5 to 10% will develop cirrhosis over 2 to 3 decades. So you can just assume what will be the population of cirrhotics with fatty liver disease.
I don't know any comments.
Yep, apart from just to add one more indication is selected hepatocellular cancers with or without background of cirrhosis. So
You think it's significant or?
it is also one of the common, maybe
Yes.
definitely down in the list, apart from non-alcoholic fatty liver disease, ETOH related disease, Hep B, Hep C. Then these tumors, selected early stage tumors within criteria, they are also treated by transplant.
Yeah, and to add to what Dr. Krishnadas was saying, many people ask, everybody does ultrasound for some reason or the other, and they find some fatty liver. What should be the advice given to them?
Yeah. Previously, we used to think that fatty liver on ultrasound was nothing. We just ignored it. But I don't think we should be doing that now, because it is a part of the metabolic syndrome. We should evaluate for the metabolic syndrome. If you just have fatty liver disease, you do a fibro scan, that is to assess the stiffness of the liver. If the liver is stiff, then these patients are cirrhosis. Even if the patient's liver is not stiff and just there is a fatty liver, you should evaluate the cardiovascular system, because these patients are highly prone for cardiovascular diseases. They have atherosclerosis, which may be hidden and come out after some time. So they die basically of cardiovascular diseases like either a CVA or a heart attack rather than liver disease. But if you have got fibrosis, that the stiffness of the liver is more, then definitely the liver has to be evaluated.
I think a recent study said that about 30% of liver transplant are done in alcoholics, and almost similar in virus B and C, and about 20-25 in non-alcoholic fatty liver disease. You agree with that? That is the same thing in Kerala also? Because the recent review in 2019 review about transplant in India, they said these figures: 30 alcohol, 30 virus, and 25 the cryptogenic.
In Kerala, it's different, sir.
Yeah.
So alcoholic and non-alcoholic actually make up almost an equal proportion. I think non-alcoholic is probably overtaking the alcoholic these days. I mean, so hepatitis B and hepatitis C are extremely rare. Yeah, because I don't know. I think it's quite rare. Hepatitis C, particularly in our population, I think it.
And how much is that acute liver failure in a pre-existing normal liver?
Yeah,
How
so
much percentage do they form?
I think maybe because we are a transplant center, it is high. It's about 20% in our series. So
50.
20%. 20%. So that's for ALF.
And one point is that most of our recipients are males. Yes. And we do, it's not a dead transplant, but it is a live donor transplant. So if you consider NAFLD, ladies have NAFLD more than men. So we're underscoring the number of NAFLD. Alcohol is different. Alcohol, basically males get it. But NAFLD, ladies who may suffer more from NAFLD, they may develop cirrhosis, but there is no donor.
So I think when a person undergoes liver transplant, can we say that liver transplant done in a carefully selected person in a good center, the results are good? Or what is your general opinion about the long-term results of liver transplant?
So I think definitely, because we are doing it, as you rightly said, it is only in selected patients. And those patients, the criteria is that they will die without a transplant within the next 6 months. That is a usual sort of scenario. And that is very true for the patients that we do transplants here. They're all very sick patients and they would die without a transplantation. So just a rough number, we have done 1,100 patients so far, of which exactly 257 have died over these years. So the rough, 10-year survival, so really the rough crude survival is almost 70%. But then if you look at the Kaplan-Meier curve and the actual survival, it will be around 60%, 65%, 10-year survival. So basically you're doing a patient who's going to die over the next few months, and they're having a normal life, absolutely normal life for the next
1 year survival will be?
1 year survival our survival is 85%, which is actually slightly lower than the Western countries. There it is 92% is the Western survey, but ours is 85%.
Is that that difference 95 versus 85? Is it because alcoholic liver disease fares worse? Do you think
No.
so, or is it?
No, no. It is
Or maybe they
predominantly
come
because-
very high
yeah,
meld,
yeah.
very
Because the patients that we transplant are a much more sicker group of patients. Almost a significant number. I think Arun will agree. They're
Yeah.
what we call as acute and chronic liver failure. Very, very sick patients, high melt patients. So that is the reason. And then we have no option for a retransplantation. If we do a liver, it doesn't work, means he's gone. But in the West, they have an option of retransplantation.
with the DDLT.
Yeah, DDL.
So, Arun, can you just explain to the audience how, why kidney transplant and liver transplant are different? The kidney transplant started way back, about 35 years back in India, in Vellore, whereas liver transplant took another 10 to 12 years and started about 20 years back and took a long time to stabilize. Why this difference? Can you explain to the audience?
See, philosophically speaking, liver transplant is a huge metabolic transplant because the spectrum of functions of liver, normal functions of liver is extremely varied, starting from synthetic, excretory and many more, coagulative, many more. Whereas kidney focuses on a particular narrow spectrum of functions, so that we are transplanting kidney just to support the functions, a narrow spectrum of functions where the patient has failed. But for a liver transplant, that means we are going to correct a huge number of,
Functions.
enzyme deficiencies, so-called enzyme deficiencies.
So in short, the number of functions carried out by the liver are huge compared to the kidney.
And many we don't know.
Correct.
That is one. And secondly, if you talk about kidney transplant, we just put in another kidney into the patient. That means it's almost always a heterotopic transplant. But in liver transplant, almost always the primary diseased organ has to be removed, especially to improve the complications of portal hypertension. With such a scenario doesn't exist for kidney. So in liver transplant, almost always it is a removal of the diseased organ and transplanting the graft into the same position as the normal liver. So that is orthotopic transplant.
Yeah. And then the option of dialysis, you would explain, is not there.
It is not there. There are some minimal improvement with dialysis support for liver, but unlike the huge advantage of dialysis in kidney failures.
The kidney patient is already on dialysis, and even if the organ doesn't pick up initially, the patient goes back on dialysis till it stabilizes, till the organ stabilizes.
So this was saying, even if the kidney fails after transplant, there is another option of dialysis for
Dialysis. The patient
dialysis.
had dialysis just before the transplant. If it doesn't work, it goes back to transplant.
Yes,
I mean, it goes back to
dialysis.
So another layer of complexity for liver in our situation is that we do living donor liver transplantation. So kidney, if you look at kidney transplant, the first ever kidney transplant was a live donor transplantation between twins, 1956. It's long. But the first living donor liver transplant was done in 1988. That took a long time because the surgery for the donor is very, very major surgery. I mean, hepatectomy and taking that liver out is a very major surgery compared to a donor nephrectomy, I think.
Is there a gender bias? Because we find that majority of the donors are women, whereas the majority of the recipients are men. Is it, we can always, in the liver, possibly you can explain saying that the alcoholism affects more men and not women. But is there a gender bias? Because why is it that more women donate, whereas more men receive? Is there a gender bias?
Absolutely, sir. Because 75% of donors are women. So I think there's no doubt our male masochistic society.
So you agree that that is...
Absolutely. And there's no doubt that women are a lot more altruistic as well. Because there's no doubt about that. I think the maternal instinct is always there. I mean, they are very, very scared to have a needle pricked in. But then you tell them, you want the liver for your child or your husband. They say, no, that's okay, no problem, you do it. But make sure I'm under anesthesia. You know, just that. It's amazing. All over the world, this is the situation. Even in US, there are more women, live donors, donate than men. So, yeah.
Many other countries, I found that the figures are not like that. I think, for example, for 45 and 55 will be in China and all. I don't think there is such a lot of gender bias in other countries.
China, I don't
but
know,
in India, it is definitely much more women are willing to donate and more men are receiving the thing.
They are exploited, sir.
How much is actually altruism? How much is forced altruism? So much of pressure is there from the peers, from the family.
Yeah. I mean, particularly if it's if it's a wife, For example, there's a, he is there, the patient is there, his brother is there, his sister is there, and wife is there. So if by any, the blood group matching has to be there. So if the blood group matches, everybody looks, of course, like, she's like,
I know people with men with chronic renal disease marry so that he can get a kidney from her, and then yeah.
Sir, it's in Pakistan.
Yeah.
Pakistan, it is something like donor wife.
Donor
That do exist.
That yeah,
That
I
do
think
exist.
so. We have to change that way, no?
Sir, can we see the same subject in a different tone, like from the recipient side? There are three important questions before any recipient, not from the donor. One, whether the particular person's liver disease is sick enough for a transplant. Is there any associated comorbid illness which makes a transplant futile? And probably the third and most important question, what is this particular person going to do after transplant? How about his financial income? Is he able to go back to his work? Is he an earning member of the family? There are so many important aspects before a recipient reaches the OT table. So in that way also, the male recipients definitely will dominate.
Yeah, Dr. Sudhi, you were talking about the blood group same matching. So unlike kidney transplant, could you explain what needs to, how is the matching done for the liver?
So even in kidney transplantation, unlike what most people believe, only matching that is required is actually blood group matching. It is just that if the HLA is matched, they may have a higher chance of long-term graft survival. But on the other hand, a living donor kidney transplant, the average lifespan, I think Dr. Kingma probably is about 20 years. I mean, average. For a cadaveric kidney, even if it's best matched, you get about 14 years. So a totally unmatched living donor kidney is much better than a totally matched cadaver. But blood group matching is an absolute must. Not exactly match, compatibility. So O group is a universal donor, AB group is a universal recipient. So that is a must. But we do incompatible transplantation when there's no way at all. But it's not ideal.
So the tissue cross-match is usually necessary for kidney, whereas it is not necessary for liver. So that is the basic.
There's a simple way to remember liver compatibility. Only O can donate for O.
Yeah.
Anybody can donate for AB. It's very easy.
Okay. You wanted to say something?
Okay.
We will do at the appropriate time.
Yeah. I think what is the timing of liver transplant? No, are we actually delaying liver transplant? Are we doing it at the right time, or is it necessary that we educate the public and educate the doctors so that they are referred to transplant at the right time? No, is it actually a delayed referral? Is it a major issue with us? What is the timing of transplant?
There is no doubt about that, sir. For example, I think in the UK, if you look at the MELD score, which is the simplest way to prognosticate survival of somebody with a chronic liver disease. So they say the average MELD in UK for transplant is actually 19. So, but for us, in our Amrita hospital, the average MELD is 29. So that's actually quite high. So essentially, it is public awareness is the biggest problem. But then, of course, there are many things which they cannot control. For instance, it's a very expensive surgery. So, you have to go through that, like 20 lakhs is a lot of money for people to spend. You need to have a donor because there is no cadaveric donor. So you need to have a donors involved. So everybody will try to delay it as much as possible. So even if the gastroenterologist says, okay, then I can transplant a ullu.
Welcome, Dr. Shabir. He is a consultant transplant surgeon at KIMS. Please join.
What happened to Subhash brother? It's coming up. So I think the delay is definitely a problem. So the referral comes at a late stage.
Yeah. We are talking about the timing of transplant, whether we are doing it at the right time or...
whether we are able to carry it out at the right time or...
Dr. Sujithan was saying that outside they do at a much lower MELD, whereas in Kerala it is...
We are getting always higher MELD patients.
What would be the average MELD in your center?
It was 26 in our center when he analyzed. That's very high, and it's a very high value for a living donor transplant, especially when you don't have cadaver.
Sir, regarding public awareness about chronic liver disease and transplant, I would say it's more important for the modern medicine doctors to have awareness. in just one.
That's why one of the reasons for this session.
In just one form. Only thing is that we just need to understand during our MBBS days or PG days, whatever, we just need to understand two things: child score for a chronic liver disease, and a MEL score. MEL score, sir was saying, model for end-stage liver disease, which is based on creatinine, albumin, and INR. It's a logarithmic calculation. And if all the post-MBBS modern medicine doctors, when they see a chronic liver disease patient at a particular point in their lifetime, immediately they ask for these three parameters and calculate MEL score. Let the patient Google about the MEL score importance and what will be his survival or her survival with or without transplant according to that particular patient's MEL score. If 3 MBBS doctors say the same thing to the same patient, they will just call up their family physician. This is a MEL score. What is my life expectancy without transplant, with transplant? So if all the medicos, all the modern medical people say the same thing to the patient, there is no problem. So I would say it's not the public, but we ourselves.
First, the doctors need to be educated.
Just not much. Only 2 scores for chronic liver disease. That should be fine. So that the average MEL at transplant will be much less sicker patient and a greater survival in the early and late phases.
No, I think next we are coming to the outcome of liver transplant. It has been said that, I can be corrected. Whenever you start a liver transplant in a center, it takes about 20 transplants to reach the good levels. And people even say that they have to get support from other centers. So till about 20 transplants, your results may not be that good. That's what I read recently. Do you agree with that? And people even say that. I know Dr. Shabir goes to the government medical college and helps them. And they say that these people should get help from people who are already established. What do you think that this the early is a consistent phenomenon that the first...
No, sir, it's like how you got training. Like when you start a unit, if you have already worked in a high volume unit, you have seen enough patients, then when you come and start, you can start with the same outcome. Maybe like when we started off...
In a new
unit. When we started in KIMS 10 years back, first 13 patients, we had no mortality. I think the 13th was the first mortality. So that is basically how you form the unit. And if there is a new unit, if they need some training, then definitely an outside unit can support.
And what about, could you throw some light on the outcomes? Which type of patients do well, which type of patients, apart from the MEL score, what are the other things which may decide the outcome?
So etiology-wise, there's no major difference between the mortality or long-term survival. Interestingly, the alcoholics have got a slightly better result. I mean, provided they don't go back to alcohol. But then again, a lot of people do go back.
That is against the published literature, I think, no?
No.
Previous literature.
They do well. They do require little less immunosuppression. So the immunosuppression-related complications are less, because the commonest cause of mortality following long-term mortality following transplantation is usually cardiac or stroke, because of partly because of immunosuppression, partly because of recurrent NASH. So the ones who are transplanted with hepatocellular carcinoma, they probably have a much higher recurrence rate and mortality. Likewise, autoimmune disease, the recurrence rate is higher. But otherwise, more or less same. But most of the mortality occurs within the first 3 months to 3 months. And that, again, predominantly depends on how the patients are presenting at the time. Because they're very, very sick patients, has had a whole lot of antibiotics, particularly the broad spectrum antibiotics. And their immunity is very low. So post-operatively, when they get an infection, they do not respond to even the highest antibiotics around, and that I think is probably one of the reasons. And of course, it's your previous question as well. It's a very technophilic operation. So it's not just like a kidney transplant. You need a urologist, you need a nephrologist. But here it is not just that. The whole system has to be there. The surgery itself, takes like 8 to 10 hours. So much of procedures are there. The anaphatic phase is very difficult to manage. So anesthetist, the intensivist, the nursing staff. So not just the surgeon alone. And can have renal problems, they can have cardiac issues, pulmonary issues. So it's a multi-system. The hospital has to be geared for that. But for Rajagiri recently started their program. Ramachandran from our unit went there. They've done 27 now, 0 mortality. So because he was experienced, the center is good. I think so it can be achieved.
Now we are talking about the outcome of liver transplant. There are many non-hepatic outcomes. For example, de novo cancer and other things like metabolic syndrome and sarcopenic obesity. Can you throw some light on these non-hepatic complications of liver transplant?
The metabolic syndrome associated fatty liver disease patients often, of course, starts at a disadvantage because they already have hypertension, they have got hypertriglyceridemia, they have got diabetes, obesity, all these are there. And post-transplant, it is found that weight gain is quite rapid, especially in the first 16 to 18 months. And it has been said that if your patient was already obese and BMI more than 30, for example, they reach the plus 30 BMI within 2 to 3 years. And if you have obesity, if you had obesity, that is not before the decompensated liver disease started, then the rate of weight gain is about 1.5 kilograms per month.
Per month.
Yeah, as compared to 0.4 kilogram per month in the non-obese person. So you can just imagine that the patient is going to gain a lot of weight, and along with weight comes all the other factors like hypertension and diabetes. And again, many of the drugs like tacrolimus, sirolimus, and mTOR inhibitors, mTOR as well as CNIs can produce metabolic syndrome faster. They increase the production of triglyceride. All are negative factors towards the metabolic factors. And once you have metabolic disease, then your heart comes in, your CVA comes in, so the mortality increases. And many of these immunosuppressants may produce secondary malignancies, may result in increased rates of secondary malignancy.
And the diabetes also more in persons under.
Pardon?
Diabetes. Okay.
Welcome, Subhash Gupta, sir. Please come. No problem. Yeah. Professor Subhash Gupta is one of the leading transplant surgeons in India, running a Max Hospital in Delhi. He underwent extensive training in transplant in UK, in Birmingham, and started the transplant program long back in India, about 20 years now, and actually initiated the biggest living donor liver transplant program in India. And his center is a large volume center, trains a lot of fellows who have spread out all over India, running successful programs in various corners of the country. Welcome, sir.
So there was one paper on the malignancies occur after transplants. I think it is supposed to be low, but they say that in India it is more aerodigestive, like pharynx and gut, whereas in outside the country it is more skin cancer. Is it actually a new thing?
Yeah. This is a very important point because what has happened that a great majority of transplants in our country now is for alcoholic liver disease. And alcohol and smoking somehow go with hand in hand. And many of the people which we've transplanted, it's only some small, not all give up alcohol. And smoking, I find that very few of them give up after transplantation. And therefore, a much higher incidence of oral cavity cancers in our country as compared to Australia, where the white people went there and they exposed to sunshine and they had skin cancer, whereas we hardly get any skin cancers. Yeah.
So that they carry on with the smoking and they have the immunosuppression on top of that. Yeah.
That's
Age. Yeah.
So I think what is the age cutoff for transplant? For example, if you look at the survival in India, the average survival is supposed to be around 60 to 70 years, whereas in Sweden and Australia it is 82 and 83. So does it mean that we have different cutoffs in different countries? So now if you take that, so an Indian may live for about 70 years, an average Indian, whereas an average Australian lives for 80 to 83 years. So does it mean that we should have different cutoffs in different countries? What is your opinion?
Again, it's a very interesting point because I'm 60, and for me to reach the age of 90, if you ask a life insurance person agent, he'll say impossible. But a person who's reached 70 is much more likely to reach 90. So, it's a very difficult question. It's a different way. But in terms of organ allocation, because disease donor liver transplantation obviously should go to the one who lived the longest. So most countries have kept a cutoff. In our country, I think it was 65 till a few years back. But now I find that the NATO has set it to 70 years.
Oh, 70 years.
So that has all automatically got corrected. It's not about, when it comes to living donor liver transplantation, it's a matter of ethics rather than transplant. Because to make someone better, some younger person should go through a major operation. I think it becomes an ethical question. And I remember having this conversation with one person, and it's a very interesting story, because his son used to live abroad, and his father used to keep telling me, why don't you come back, So he needed transplant. He said, I'll give my liver and he'll never trouble me again to come back. So we've been variable in our age, but I think 70 should be the upper limit.
Yeah. And does it?
Any country.
Most countries, even UNOS would not accept more than 70.
And does it also depend on the keenness of the next of kin to donate? The decision on the age?
Well, the funny thing is again here that if you show hope, most kins will come forward. So I think at some point the medical profession has to set the standard.
Dissuade them or
Yeah,
probably?
yeah, because show them hope. Everybody wants to have that extra year. I think we must be careful and say, we should not be doing it.
What about, Dr. Gupta, the cutoff? Is there any age cutoff? I mean, the ideal age cutoff for the donor?
Yeah.
Is it said at 50? Till what do you go in your practice?
We have now, the oldest donor that has been reported in literature is 76-year-old. Spouse, I'm forgetting whether the wife gave to the husband or the husband gave to the wife, but they were both with 76 and 77. That's the oldest that's been reported. Japan, which has probably one of the countries where a lot of people live beyond the age of 100. So there the cutoff is 65. In our country, we've kept 50 and 55 because mostly, unfortunately, and it's a matter of sadness also, that most donors are females. Males are just reluctant to donate. I don't know how it is in Kerala.
Yeah, we've been just discussing that, I think.
It's impossible to persuade the males to donate. And most, people in India, females, they have kind of not taken care of themselves, osteoporosis.
Many a time people say that women are forced. It is said that in renal transplant, many families force their daughters and the women to donate the thing. It is not that they are altruistic and give forward and come forward and donate.
If I were to make a controversial statement, I'll agree with you 100%. The only true altruistic donation that I've seen comes from mother to a child.
Mother to a child.
That is the only one altruistic I've
Not
seen.
even father to a child. Not even father to son.
Father to son, no parents, father. But mostly altruistic. But first they'll always put the mother first.
Mother first.
And in the other groups, there is some amount of consideration, which I'm not sure whether you can call, whether it is truly, but there is a certain amount of other factors under consideration. So I know cases where brothers have donated, and then in return they've asked that the property be given over in their name. I know of cases. So I don't think it's truly altruistic that
Donation, yeah. Now, what about, I read somewhere that one of the issues in donors is donor suicide. Do you think it's a problem because donor suicide has been described?
Yeah.
There are reports of donor suicide. Now, do you think it's a real issue?
It is a real issue, I think, because, for someone to be brave enough to go out with donation, they have to have a little slightly different bent of mind. So in every literature, every report all over the world, including our own series, I know a girl who donated to a mother, and then about 15 years later, she took a lot of midazolam tablets, and she's actually so there is a higher incidence. But I don't think it's really, it's not a big issue, but there is a higher issue. But you see, what happens is if you look at...
That you can hold the mic.
Okay. Okay, can it better? So, in every population, this has been noticed that there is slightly higher incidence of suicide. But I think it may also be a fact because this donor population is looked at very closely. I was in a meeting somewhere in which there were thousands of people there,
and they were discussing donor mortality. So the one person from the audience got up and said, if you follow up so many people, at least one person will die and die. You know? So I think if more closely you look at, then sometimes you get taken astray. But I think the donors, we tell them that, it's a big operation and you may actually die for it. Still to go ahead means that they are slightly different from the average population.
Do you think, how far, for the benefit of the audience, donor workup, are lifestyle diseases a hindrance in getting donors early enough, and how, if found, how early they can be modified?
I assume you are for donor selection if they have
Fatty liver.
Yeah, fatty liver. I think fatty liver, I think we have to make a little distinction here. There's fatty liver and steatohepatitis. Those if the enzymes are deranged, then perhaps we should not go ahead, because these people who will eventually end up, and particularly all donors are related, so they may have a sort of a genetic tendency to become have fatty liver disease later on. So we try and not take from them. But if it's just simple fatty liver, which is, the enzymes are normal and there's fat, they lose, and most of them, interestingly, most of the fat gets deposited in the sort of right side. Perhaps, we may recall from physiology that all the meal that we all, that's all abscesses and everything tend to happen on the right lobe. So fat even is preferentially deposited on the right side. So if they lose just about 5% of the weight, that fatty liver usually gets corrected very quickly. And some, I find that normally they would not bother, but if they are under pressure to save their near and dear one, they quickly lose this weight.
And then they also get time to get adjusted to the concept of transplant and get mentally prepared for that as well.
That is very important.
What percentage of donors get excluded because they have got NASH? For example, Krishnadas was saying that about 30 to 40% of the population has fatty liver disease. So what percentage of donor, when they come for workup, you say that he has got NASH. So what is roughly the percentage who are not refused as donors?
So let's look at it in a slightly different manner. If you look at donors, I would say 60 or maybe 70% donors are females. Females strangely seem to have protected from, at least in our population, protected from fatty liver. Whereas the males, in fact, I would say almost every male would have fatty liver, not steatohepatitis, but we are, I would, if we were to, out of this pool, if their enzymes are deranged, they'll have liver biopsy. And I think about 10-20% of these male donors would have beginning of steatohepatitis. And we have to be very careful in that group, because this group eventually will end up with the same disease as their relative.
Given a choice,
much higher in our population. Males, much higher. Males, 50% will have significant steatosis that we cannot
include them.
Majority, but as he said, females are somehow protected. Even if they're a little bit obese also, the liver somehow seems to be non-fatty. But even then, I would say 20% will have steatohepatitis.
Yeah.
I mean, not the huge amount of hepatitis, but raised enzymes to the level that, raised SGOT-PT or gamma-GT, which we can't take.
Yeah.
So our commonest reason for exclusion is fatty liver.
Even diabetes. Here, I think, Krishnadas, did I understand that you are saying that more fat in women? And, did you say like that?
Yeah, that is what the literature says, but most of this is from the West.
Most of?
This is from the West. They say that ladies have a higher degree of fatty liver.
Ladies have higher liver.
Yeah, it's just the opposite. What we feel in the donors is exactly the opposite. Because visceral fat deposition is less for them, more of body fat deposition.
So I think I'll ask a question to the surgeons. Now, if you are given a choice, would you prefer to do an LDLT or DDLT?
It's obvious answer, DDLT.
Yeah.
DDLT is the obvious answer.
DDLT,
Yes.
everyone would, what about you, sir? Yes. Would you prefer a DDLT or an LDLT?
Depends on which continent you are.
No. If it were, there are inherent problems with DDLT in this country. Let me just enumerate that. First of all, it's quite often a fly-by-night operation. So when you do a fly-by-night operation, you cannot have the best teams available. And majority, we have very good gastroenterologists, hepatologists.
Can I just make a, for the benefit of the general audience, DDLT is disease liver transplant, whereas LDLT is a live donor.
So the patients who are coming up for transplantation now, I don't know how it is here in Kerala, but at least those who come to us are those with ACLF, those with high MELD scores. And to them, sometimes if you do a DDLT operation, a disease donor operation, you may not get the best result because you haven't had the time to prepare them, optimize them for the transplant. So looked at that context, I would say LDLT is better because LDLT can apply in, you have planned date, planned operation, Dr. Shabir is not on leave, Dr. Sundar is not on leave, the anesthetist, everyone is around for that particular case. Whereas if we do a DDLT, if we were an abundant supply, like in the West, where patients are quite often, we have at least, sometimes we have 20, 30 people on the DDLT waiting list, and you cannot contact them in time because they've just either, I don't know what has happened to them. So that way, but yes, from the transplant surgeon point of view, we would like DDLT. We have no, we feel happy, we have no...
Provided the donor is well maintained preferably in-house DDLT.
Yeah. In-house DDLT is probably the best. So what we've done actually, because DDLT in North is so uncommon, we end up giving it to the patient who is scheduled for transplant in the next week. So they've already been optimized, and so then you get the best results from that.
Shabir, you wanted to say something?
Here, that depends on the situation. How is your organ availability? Definitely, technically, as sir said, DDLT is the best because you have no tension. The other operation is a very complex operation, at least some 50 times more complex operation. LD, living donor, definitely. And you have one side the risk of donor morbidity and mortality.
And after working up many donors, live donors, you may find that many are unsuitable. That problem
is also there. So if definitely in any country we should promote DDLT, since it is not possible, that's why this LDLT has come up in our country.
Yeah.
I would like to make an important point here, which I did yesterday as well. At least 25% of donations in the West are now after cardiac death. And most hospitals, as in Delhi at least,
so for natural
birth and natural death is gone. Everybody dies in hospital. So there's a huge source now for donation after cardiac arrest. Huge, because the technologies come, ECMO is there, machine perfusion is there, and we've so far not done. Maybe Dr.
Shabir, for the benefit of the audience, can you explain what is DBD and what is
brain death? Brain death is you've got a brainstem, usually brainstem hemorrhage or a stroke or a tumor that has actually caused the brain to be cut off from the rest of the body. So because the heart has got a pacemaker, it will still work. So provided you put them on a ventilator, because the brain is gone, you won't breathe. You cannot breathe. So if you don't put them on a ventilator, a brain dead patient will die within the next 15 minutes. But if you put them on a ventilator, then you can ventilate them and the heart will go on beating and the rest of the organs will therefore be supplied by the blood. And you can use those organs till the heart stops beating, which may take about a week. So that is a brain death. So in a brain death patient, the ECG is normal. The patient will sweat because they've got sympathetic function is still intact. But we can diagnose brain death by the certain tests like your pupillary function, your apnea test, etc. In a cardiac death means the heart has stopped working. So once your heart stops working, your organs will lose the blood supply. And within 10, 15, 20 minutes, depending on the organs will lose its viability and you can't use them. So now in the West, that is a common thing. For example, somebody in the hospital is going to die. We know that his terminal is going to die. Then we get the permission from the relatives. And if they're willing and we know that he's not going to come out, then as soon as they have the cardiac arrest, within 5 minutes is allowed. And within 5 minutes, they're taken to theater and immediately organs are perfused and they're taken out. So that is a cardiac death. But sadly, in our population, the issue is that so normally these are patients who are sick or on the ventilator, and once the relatives agree, what happens is the ventilator support is withdrawn. That is what that's the commonest way. Yep. But that thing is not legally valid in India as of now. So it is not possible. So the ones that have in India are the ones that already become brain dead, but are had a cardiac arrest. That's what happened in PGI.
Without brain death, in the absence of brain death, DCD is not possible.
It's
as of
very
now.
because we
Can
cannot
be
take
done.
off the ventilator. We cannot withdraw.
There is no legal contraindication.
There's no
Well,
legal-
There's no legal contraindication.
There is a legal contract for stopping ventilation.
And
Stopping
one.
Yeah.
for removing
He's in
organs.
a
No.
cardiac arrest,
Yeah.
and he can be put on ECMO, and you can
Yeah.
theoretically you can do it.
You can do it,
We
yes,
can
yeah.
push for it. And that's what I'm saying.
There was a very interesting article. I don't know whether we should believe that. It said that religiosity increases survival after transplant. This was from Italy paper, and then another paper has come from another where they said that if people compared the survival of persons who believe in God and who do not, and came out with the data saying that people who believe in God or religiosity, they survive more. There was definitely a evidence way. I don't know whether we should, it's an evidence-based study or not. But what I said was that, is religion coming in the way of DDLT or DDLT? Is religion coming in the way? Because we know that when scriptures were written, there was no liver transplant, except the example of Ganapati. So now we always assume that people, Pandits give an explanation saying that you are to be born again, you should not give your organ. Whereas there are other people who said that when you are born again, it is your spirit that goes into another body. So is there religious objection to DDLT? Or
I want to give you a historical anecdote on this. In Japan, there was a Japanese surgeon who went to US and trained in liver transplantation. He came back and he did a donation, retrieved organ from brain dead person transplanted. Unfortunately, the surgeon went to jail.
Japan, there's no DDLT.
So the Shinto sect of Buddhism, they believe in what you're saying, that if you take the organs out, you will be reborn again with the minus those organs. But apart from that, I think DDLT is flourishing in Saudi Arabia, DDLT is flourishing in Christian world. Only our country, it's not flourishing. And I think there are a lot of issues here. I don't know.
I think it's there is definitely a religious divide in Kerala situation. There is definitely a religious divide in donation. In DDLT, DDLT donation. DDLT, I'm talking about DDLT. Living donor, there is no difference. Everybody, if somebody, their close one is sick, they will definitely donate. No religion has any problem. The problem comes in DDLT because of these beliefs. But in Kerala, if you take the statistic, there is definitely one or two religions are on a backside. Maybe on the front foot is Christians. They have the highest number of donations because it has been there in all churches and all. It has been told that it is a thing to be done. All other religions, they haven't ever declared it. Although there is no rule against a DDLT in any religion, any major religions now.
Yeah.
But as sir said, now Iran is picking up, Saudi is picking up. But still people here, no, if the scholars and all, they are not even interested in looking at this issue. They are discussing something else. That may be the reason.
I don't.
Just to add on to the one subgroup of Christianity, everyone knows Jehovah's Witness. They don't accept blood products from, I think even albumin, they don't accept blood and blood products from other persons. So Jehovah's Witness, a subgroup.
There's a very small group, but I think they have donated. When I worked in UK many years, we had donors from them. But I don't think there is. I mean, on that there's clear agreement. There's religiosity. I wanted to come to your first point, what faith. If you look at patients who have faith in you, they do better than patients who don't have faith in you. So maybe faith and religiosity I sometimes equate together.
Sir, in general, surgical outcome is like that, not just transplant. Even a laparoscopic cholecystectomy, faith to the surgeon and team, half done.
So I think we have spent had a good discussion. So parting comments from Dr. Subhash Gupta.
I think one important message that I'd like to say always that adult liver disease at least is preventable. And we should go a long way in trying to do that. I mean, hepatitis vaccine, hepatitis C treatment, immunization of newborn, fatty liver disease, cut down on carbs, cut down, do a little bit of exercise. Hardly anybody is exercising. They're all going to the gym. I think that makes the liver worse. I don't know. They need to play some kind of active sport. And that's all, and this fatty liver is really becoming a big, terrible it is, I think.
Others, Doctor, yeah.
I would agree 100% with Dr. Subhash that prevention is the way forward. So HPV, HCV is on the way out. HCV, I think in 10 years there will be no HCV. Maybe in
HPV
another 20 to 23 years, 20 to 30 years there will be no HPV because vaccination will take over. But the thing will be metabolic disease associated fatty liver disease.
HPV and HBV, you think we have lost precious 10 years because routine vaccination didn't start in early 90s?
Yeah, maybe if that started at that time, probably it would be along with HCV. There will be no HCV or HPV in 10 years.
Yeah, Dr. Sudhi.
I think my thing is liver transplant or all organ transplant should be something which is freely available to everyone in the government setup. So a lot of public-private partnership is required. I think that's very, very, very crucial because cost that prevents. And second thing is I think we should, as doctors, it's our duty to make sure that we're all organ donors, and that's the best way to promote. I think it's very, very important.
We are very happy that we are on the threshold of this institution is on the threshold of restarting a transplant program with help from all of you. Arun?
Trust and faith, nothing else.
Trust and faith. So thanks to all the eminent panelists. Thank you, sir,
Thank
for
you, sir.
co-chairing.
Thank you.
Thank you, the audience.
Yeah, we are extremely grateful to all of you. They were all in another big conference happening in Poa, and 2 hours they took travel here, and so we are especially to coordinated by Dr. Shabir Ali, and also the chairpersons. And now I request Vasudevan. Pardon? Dr. Vasudevan, please. He's he's a nephrology, transplant urologist, and one of the senior most urologists in Kerala. And he wants.
Personally, this session has been of very great interest for me because promoting organ donation as well as organ transplantation has been my mission for several years now. And Dr. Subhash Gupta is member along with me in the IMA National Organ Donation Committee. So great to have you. Over 3,000 transplants, and we should understand that the cumulative surgical experience of this team is so huge. 3,000, more than nearly 300, 325, 1,000. And Shabir, 400. And yes. And Ramesh has a huge experience in casing, and he is on the verge of seeing now. So what we heard was really a huge panel, from a huge panel, and it has been great pleasure having you here.
Thank you.
We request the moderators to hand over the certificate of our appreciation to the panelists. Dr. Subhash Gupta, Dr. S. Sudhindran, Dr. Shabir Ali, Dr. D. Krishnadas, and Dr. Arun Kumar ML. First, to Dr. Subhash Gupta.
Now, yeah, please stay back for a two. That's it. I request all first prize. So please, I request the GM of Sunny Diamonds. Please
Next
come.
we are
Yeah.
Next we are moving to Lucky Draw Contest conducted by Sunny Diamonds. The Lucky Draw Contest winners of Toronto.
I invite our principal, Kalakacha madam, to spin it. Yes.
The Lucky Draw Contest winners of Toronto Medical College Platinum Jubilee celebration will get first prize, handcrafted ring studded with internally flawless diamonds from Sunny Diamonds. I request the principal to spin the win. First prize, handcrafted ring studded with internally flawless diamonds from Sunny Diamonds goes to Gauri V. Anil Kumar.
And the proper, yeah. This is the ring with a diamond. This is the first prize. Thanks for the diamond. And one we have
Second prize,
Gauri V. Anil Kumar. I request the principal to receive it and probably hand it up. That they will end. And the second prize.
second prize, rupees 5,000 worth gift card from Sunny Diamonds goes to Abel Jerson K.
Yes. This is the 5,000 rupees for the card. It can be utilized here after purchasing the diamond. Third prize. The phone number, everything is there. I will tell you. Any problem with taking? Third prize will go to our principal head.
Third prize, rupees 5,000 worth gift card from Sunny Diamonds goes to
Our principal.
our principal, Dr. Kalakeshavan ma'am.
വേറെ ക്ലെയിമന്റ് വന്നാലേ നോട്ട് റീഫണ്ടബിൾ. നമ്പർ എനിക്ക് തരണേ.
അതൊക്കെ ഇവര് തന്നെ വിളിച്ചറിയിച്ചു. ഇവര് തന്നെ വിളിച്ചു. Now, കസേരയൊക്കെ എടുത്തിടോ. Vinod, Lakshmi, Dr. Kavita, all the team who has worked very hard in the last few weeks. And anyhow, without much fault. We could complete this despite, I was telling, organizing a conference in a 5-star hotel and organizing in a government college are entirely different. And I am sure you all will bear with whatever the deficits are there. And so that is, anyhow, we are extremely happy. And the scientific program, especially Dr. MKC and Dr. Vasudevan, they had done wonderfully well. Wonderfully. Actually, scientific programs are this conference a beauty because not even a single talk was of low standard. Top class. And the speakers also were top class. So, thank you very much, and we will. Yeah. Yes, thank you.
I request